Assalamu alaikum wa rahmatullahi wa barakatuh, dear colleagues and friends. Today, we are going to have a short review about the emergency contraception, and we will have all the possible tasks that appeared before in the exam. We are going to speak about the emergency contraception together with cervical dyscryosis or patients who are going for LITs, patients who are asking for contraception after delivery and she has a breast cancer. And there is one more scenario that appeared before long time, but it doesn't appear in the recent recalls. If the patient has a problematic bleeding and she's on contraception. So the emergency contraception is a repeated task in the exam. Almost all the exams in February, November, and May, you will find a task about emergency contraception. It is full of safety points, full of communication. And you may find a lay examiner in the task, so you have to take care. If you find a lay examiner, the marks will be doubled. So, general informations. What are the types of emergency contraception? Type 1, levonorgestrel, or Plan B, Levonil. The dose will be 1.5 milligram up to 3 days after unprotected intercourse. It's only given before ovulation to prevent the ovulation. And it can be repeated for several times. So the Levonil can be repeated up to several times. If she had more than one unprotected intercourse, she can have the Levonil to be repeated. No interaction with other hormonal methods. So if she is using any other hormonal contraception, she can continue without any problem. And the dose will be 3 milligram. It will be doubled if the body mass index is more than 26. And if she is on enzyme inducers. Second type will be L1 or olipristal acetate. The dose is 30 milligram and it can be used up to 5 days after unprotected intercourse. So in Levonil, she is using the dose up to 3 days after unprotected intercourse. In L1, up to 5 days after unprotected intercourse. It's only given again before ovulation to prevent the ovulation. And it's better avoided. If there is bronchial asthma, the lady is taking antacids, and if her weight is more than 85 kilogram, or the body mass index is more than 30. And if she's breastfeeding, she has to stop the breastfeeding for 1 week after taking the L1. So both of the first two types, they are working by preventing ovulation. La Levonil, up to 3 days after unprotected intercourse, and the L1 for 5 days after unprotected intercourse. The other points mentioned here, these are the important points that has to be asked during the information gathering. These are the points that you have to confirm that you mentioned this point during the history taken to exclude the contraindication for L1, for example. The third type will be copper T. The copper T has a high success rate, 99% out of 99% or 99 out of 100 when you are speaking to the patient. It acts by preventing the sperm fertilizing the egg and by preventing implantation. It can be used also up to 5 days after unprotected intercourse. And it can be inserted immediately after LITs, but do not postpone the LITs for EC. We will have a scenario today about the patient who's coming for emergency contraception, but she has LITs procedure. So do not recommend to postpone the LITs. The lady can insert it before the LITs, can insert it after the LITs, but do not postpone LITs. If you insert it before the LITs, this may lead to cut the threads short, and there will be a difficulty in removal, and she may need hysteroscopy. So these are the 3 options for emergency contraception. Big trap that the candidates will fail. Sometimes in the history, and it came before, there was no indication for emergency contraception. The lady came and she was in regular contraception, and she was in the 2nd week of her cycle, and she was taking the contraception reliably. She only forgot 1 day, and she's coming for emergency contraception, and almost all the candidates were going through the emergency contraception, and they started to describe which type she will need. But sometimes you may not need emergency contraception. All what you need will be a backup method. So we'll go through the usual steps. If she missed one pill, she will need to take this pill as soon as possible, and she will continue in the usual way and usual time. Does she need emergency contraception? There is no need for emergency contraception here. Very few occasions, if she missed the pill earlier in the pack or in the last week of the previous packet. So if she missed one pill, all what she needs to do is to take the missed pill once she remembers it, and to take the remaining pills as usual. And there is no need for backup method, and there is no need for emergency contraception. Second scenario, if she missed or more pills, what she's going to do? This point, she has to use a backup method. She has to use a backup method, means, for example, she has to use condoms. What about the missed pill? Does she need emergency contraception? This will depend on the duration of her cycle. So if she missed the pill in the first week, she will need emergency contraception. If she missed the pill in the second week, she will not need emergency contraception, provided that she was taking the contraception before consistently and correctly. If she missed the pills in the last week, means she will not need emergency contraception, but she will omit the pill-free interval. So once she finishes this pack, she will start the next pack immediately. So take care, please. You need to ask about the last menstrual period. You need to ask if she was taking any contraception or no. And if she's taking contraception, if she was taking the contraception in a reliable and correct way or no. It appeared before there was one task and there was no indication for emergency contraception, and almost all the candidates, they fail in the trap. One old scenario that came before, one lady, she came with intermenstrual bleeding and she was on hormonal contraception. So if you find this task in your way, what will be your plan of management? So, woman with hormonal contraception and she has a problematic bleeding, usually will be intermenstrual bleeding. So the first steps in the management, you have to take a clinical history, you have to exclude sexually transmitted infections, and you have to check her cervical screening history, and you have to do a pregnancy test. These are the first steps, and all of these steps are very important in the safety and in the information gathering. In the information gathering, you need to know what's her concerns, if she's using the method correctly, if she's using any other medications that may interact with the medicine, and other symptoms like pain, dyspareunia, or abnormal discharge. These are the important points in the information gathering. If you have a patient who's coming with intermenstrual bleeding and she's taking the contraception, definitely you have to exclude STIs, you have to ask about the cervical screening history, and the need for a pregnancy test is mandatory. Okay, how to manage any issues according to the history. So, if she started taking the pills less than 3 months, so the management will be different than if she started taking the pills more than 3 months. If it is less than 3 months since starting the pills, you have to check for the upper information. You have to exclude STI, you have to exclude any abnormal cervical screening, and you have to exclude pregnancy. If all normal, there is no need for examination, there is no need for investigation in this case. No need for examination, no need for investigation in this case. If all are abnormal, if all are normal, you have to reassure the lady and arrange follow-up. If she requested medical management, you may offer her mefenamic or tranexamic acid. This is the first scenario. Then you will give her a follow-up. If the follow-up, the problematic bleeding settled, you will continue the same method. If the bleeding persists or the medical treatment failed, you will do speculum examination at this stage. So the examination and the investigation will be after 3 months and after medical treatment failure. in the first scenario if there is no abnormality in the primary assessment. Second scenario, if she started taking the pills more than 3 months and she's still having persistent bleeding, or she developed new symptoms, or the medical treatment failed, or she's not participating in the cervical screening program, or if she's requested by the woman preferences, woman wishes. So what are you going to do in this case? You will do a speculum to assess the cervix, and if there is any associated dyspareunia or abnormal vaginal discharge, you will do speculum and manual examination. So this is the pathway till now, depending on the primary assessment, if it is all normal, less than 3 months or more than 3 months. Less than 3 months, no need for examination, no need for investigation, and only follow up. After 3 months, you will see if there is persistent bleeding or failed medical treatment, you will do examination and investigation. More than 3 months associated with any abnormality or associated with pain or dyspareunia or abnormal discharge, you will go for speculum and bimanual examination. So after 3 months, if the problematic bleeding has settled, continue with the method. There's no need to do anything. The speculum or bimanual examination show any abnormality. If you find any clinical finding, for example, fibroids, polyps, erosions, whatsoever, you will manage according to the finding. By examination, all normal, there is no abnormal finding, you will see the symptoms. If there is no other associated symptoms, you will reassure the woman and consider medical management. The findings all are normal, but she has symptoms. Her age is more than 45, or her age is less than 45, but there is associated risk of endometrial cancer. In this case, you will consider further investigation, further assessment for the endometrium, either by ultrasound or biopsy or hysteroscopy to exclude the possibility of pathology. So this will be your plan if you are going through this task. If you find a case of intermenstrual bleeding, what is the medical management? It will depend on the method the lady is using. She's using combined hormonal contraceptives. In general, you will not do anything. You will just continue the same pill for the first 3 months. Usually the bleeding will stop. Or you may use combined contraceptive pill with a higher dose of ethinyl estradiol. Maximum dose 35 microgram. The recommendation to use a different contraceptives or change the type of progesterone or increase the dose of progesterone in the combined oral contraceptive is not an evidence base. If she's using tablets, she's using pills, you can use the vaginal ring, contraceptive vaginal ring. It has a better cycle control. So these are the management steps if the scenario came with a lady who is taking combined hormonal contraceptive. Either continue or use combined oral contraceptive with a higher dose of ethinyl estradiol, or use contraceptive vaginal ring, which has a better cycle control. What if she is using progesterone only pills? In this case, the first step is to change the type of progesterone only pills. If she's using the traditional POP, you can change it into desogestrel POP. So this is the first step. The second step, there is no evidence to support the use of 2 pills. You will find some people who are advising the patient to take 2 pills instead of 1. There is no evidence. Sometimes there are recommendations to give the patient low dose of estrogen or to give her tranexamic acid, but this may be of benefit on the short term, but on long term, it has no benefit. So this is for progesterone only pills. If she's on progesterone only implant or injectable contraceptives or on Mirena, first step is to give her combined oral contraceptives. And the dose of estrogen will be between 30 and 35 microgram. She can use combined oral contraceptives with her method for the first 3 months. There is recommendation to reduce the interval between injection, which is not supported by evidence, and to reduce the duration of bleeding. You may consider giving the patient mefenamic acid or tranexamic acid this may help in the short term, but not on the long term benefit. So this will be the scenario if you find a case coming with emergency contraception. What are the available options? Either tablets or IUCD. And if a lady coming with intermenstrual bleeding and she's on combined or whatever the hormonal method she's taking, how you are going to evaluate the case, how you are going, the management will be the diagnosis. The diagnosis will be by the history. If you need examination, if you need investigation, it will depend on the duration and the associated symptoms or associated abnormality. If the lady is having hormonal contraception and she has problematic bleeding, the management will depend on the type of contraception or on the type of hormonal treatment she's taking. If the lady asks you during the discussion, I have a fibroid, this will need further assessment and involve the consultant. This is the answer. If she's having heavy periods, you have to counsel her that the IUCD will increase the amount of menstruation. If she asked you after inserting the coil when to remove the coil, if she wants to start the pills, so you will remove the coil 2 days after starting POP, 7 days after starting combined oral contraceptives, and 9 days after Claria. So these are the safety times to remove the coil. You have to start the tablets first, and then after 2 days, if you started POP, remove the coil, 7 days if you started combined, and 9 days if you started Claria. Okay, what if the morning after pill is suitable and she asked when to restart my pills? She is taking emergency contraception now, and she's telling you, I need to start a hormonal method again. What will be your advice? Advice is to wait for 5 days before starting anything. During these 5 days, she will need extra precautions. She will need condom as a backup method. Then she can start the pills. Will she continue on the backup method after starting the pills? Yes, she will continue for 2 more days if she's using POP. So 2 days plus 5 days, it will be 7. She will use a backup method for additional 7 days if she's using combined oral contraceptives. So 5 plus 7, it will be 12. And it will be 14 days if she's using Claria, which is 5 days plus 9. So if she agreed for the emergency contraception and she will ask you during the discussion, I need to start combined oral contraceptive or I need to start my tablets again, the backup method, and when to start after 5 days. The backup method, you will continue on the backup method for 2 more days after starting the hormonal treatment if you are using POP, 7 days if you are using combined oral contraceptives, and 9 days if you are starting Claria, and the same for all other methods. If she needs post-exposure prophylaxis, there is no problem. It will not affect efficacy of the contraception. If she's breastfeeding and she's using L1, she has to stop the breastfeeding for 1 week. Very important points. If the lady wants to start contraception in the first 3 weeks or in the first 6 months and she's lactating, she can postpone if she's willing. The lady immediately post-delivery and she wants IUCD, the safest period to insert the IUCD either in the first 48 hours or after 4 weeks. If she's insisting, respect her wishes and counsel her about the higher risk of expulsion and the higher risk of perforation. If you offered her pill, you have to counsel her that her periods may be delayed. But if the delay is more than 1 week, she has to come back for pregnancy test. Or if the delay is more than 3 weeks after the unprotected intercourse, she has to come back for a pregnancy test. If she has swabs showing chlamydia and she wants to insert IUCD, still you can insert, but under antibiotic cover. Again, L1 is not suitable. You have to ask about the bronchial asthma and the use of antacids during the information gathering. If the patient has allergy to nickel, the IUCD may be contraindicated. If she asked you, or if she's going to tell you in the task, I don't believe in abortion, I don't want any method that may cause abortion, and she's refusing the emergency contraception, you have to tell her that there is no evidence that oral contraception that can cause abortion. It is only working by preventing ovulation so earlier before the onset of pregnancy. Because again, these are all the questions which were asked by the role player in such task. Emergency contraception and contraception in general are repeatedly coming tasks in the exam. So we will have 3 tasks today about the emergency contraception and the contraception after delivery. We'll start with the first one with Dr. Wafa. Dr. Wafa, are you there?
Yes, I am here.
Okay.
Okay.
Dr. Mariam. Minutes. Write your notes, Wafa, please. Write your notes in the chat box. Okay, Mariam. Mariam, are you there?
Yeah, I'm there.
Okay. So now we are going to fix the 10 minutes. Sorry.
Good afternoon, Donna. How are you?
Good afternoon. I'm very well, thank you.
My name is Wafa. I'm one of the doctors in the clinic. And I understand from your notes that you had unprotected sexual intercourse and you seek emergency contraception. Is that correct?
Yeah, I had unprotected sex with one of my friends. And I want to know, like, what if I'm pregnant?
Absolutely understandable, Donna. Don't worry about anything. We're here to support you and guide you over the next step. And I want to assure you that everything that will be discussed today will be kept in complete confidentiality unless you allow us to disclose it even to your GP.
Okay. Okay, thank you.
So, yeah, sorry, carry on.
Thank you.
You're welcome, Donna. Donna, before I carry on today, is there any other specific concern rather than other than pregnancy?
No, actually, this is the main.
Okay, so Donna, before I carry on today, I'll have to ask you a few questions that are very important to your management. They may be felt a little bit intrusive or embarrassing, but they're important. Then I will go through what is possibly could be your options. I'll give you an information leaflet to summarize everything. And then I'll write back to my consultant and arrange an appointment, and also write back to your GP and the specialized nurse and give you support on counselor if you wish to. Is that all right?
Yeah, that sounds okay, doctor.
And also side effects, unwanted and red flags, and how to contact us and later on.
Okay, that sounds okay.
Okay, so Donna, if you don't mind me, tell me, when was this unprotected sexual intercourse?
It was 4 days back.
Okay, was there any during this cycle?
Sorry?
Was there any before that during this cycle, or this is the only one?
This is the only one.
Okay, that's fine. And if you don't mind me asking, you said with one your friend. Tell me a little bit more.
Actually, me and Matt are not exclusive. We have been seeing each other for the last 6 months. I'm not dating anyone else, but I'm not sure about him. So we have sex, unprotected one. And while I was discussing with my girlfriends about our, relationship status, so they pointed out, what if I become pregnant by having an unprotected sex? So it made me really worried. And since healthcare center is closed today, so I didn't know where to go, so I came here.
Oh, absolutely understandable, Donna. It can be a little bit stressful when you're not in a quite long, reassured relationship. So would you say that things between you and him, was it consented sex?
Yeah, it was.
Okay. And have you ever had any sexually transmitted disease in the past?
And no.
Okay.
And I don't think it's important either, because I have been in a monogamous relationship whenever I was in a relationship.
Absolutely, I understand your query, but sometimes, like I said, it's very important to your management to make it safe for you. So Donna, when was the last time you had your cycle?
10 days back.
Okay, and is it regular?
Yeah,
okay.
I never had problems.
Okay, thank you. And do you use any contraception?
No, condoms on and off. This is it.
Okay, that's a very brilliant point, because it protects you from sexually transmitted diseases like you will do it. So are you otherwise fit and healthy?
Yeah.
And have you been pregnant before?
No, never.
Okay. Do you know your BMI?
It's 23.
Okay, thank you. And have you had any surgeries before?
Nothing important, actually.
Okay. What I want to inquire about is precisely a cut down below, or what we call female genital mutilation.
Yeah, I had it.
Okay. If you don't mind me, I will just inquire a little bit more about it. Was it in the past or recent?
It was past. I cannot even recall. When was it?
Okay, I'm so sorry to bring such a bad memory. I can see how tense you become when we abort it, but it's just part of the questions that are important to you. So, do you have any allergies?
No, I don't.
Okay. And do you take any drugs continuously?
No.
Okay. And whom do you live with?
I live in a hostel, college hostel, with my friends.
Okay. And if you would you say that you will support it?
Yeah, I am.
Okay. Thank you for sharing all these intimate questions, Donna, about your life. I really appreciate it. So now we're gonna come into your options. You do have few pills or a coil. The pills, there are two types, one called olipristate acetate and one called Livonella. And actually, Livonella is not an option anymore, because that use only on 72 hours after the unprotected intercourse. But you still have the other pill, and it's quite successful up to 98% of women. And it acts on releasing the ova from your eggs, what we call ovulation. And the other method will be a coil, will act on double action, releasing the egg, as well as if the egg is fertilized by a sperm, which can be your case because of you're still in the ovulation period. It will stop that and stop it from attaching to the lining of the womb. Am I clear so far? Do you have a question?
Yeah, actually, doctor, I'm really afraid of this coil thing because I've heard horrible stories about it. And as far as pill is concerned, I tried it 2 years back. I don't know which one actually, but it made me really sick. So I'm worried, what if it happens again?
That is absolutely fine, Donna. It can be a little bit overwhelming having a coil and painful. And the tablet, yes, it's quite known to vomit. And because it is your case, if you go for that option, I will make sure to give you some anti-sickening tablet, and that will help. And if you vomit 2-3 hours after, we will just need to repeat it. But the coil, if you choose to go for that, it can be a little bit intimidating, has few side effects, and I'll go through that if you decide to. Do you wish me to do that?
Yeah, please go ahead.
So the coil can be fitted now in the clinic, and the nurse will be here. We'll give you some pain relief for the cramps. It is quite effective. It can be a long-term contraception to prevent any unwanted pregnancies in the future. Don't have to worry about it because it's there. Although there is no 100% certitude that it will work, it's up to 99% efficient. There is a small risk of injury to the neck of the womb and to the womb, and if that happen, we need maybe to just observe you, have a look. In really rare cases, Donna, that we need to go for a keyhole surgery. In my expel, that is really small, and really a small kind of people have an allergy to nickel. It can be applicable also to copper, but you did say you don't have any allergy. So that's why if you feel unwell, itchy, short of breath, or have pain in your tummy, you have those contact numbers that I will give you at the end. You just call us and come back. And to the main concern, which is pregnancy, if your next cycle, we expect it to come on time. If it delays a little bit, that's okay. But more than 1 week, we want you to do a urine pregnancy test. And if it, in both methods, obviously, and it comes positive, you need to call us because the risk of pregnancy is there. And in case of coil, if you choose to go for that, it might be outside of the womb, what we call ectopic. You need to come, do a scan, and we'll take it from there.
Okay, and doctor, can I use the combined pill?
Absolutely, Donna. That's actually a very good suggestion from you, showing that you're really keen on protecting yourself and being safe. You can use it in the next cycle. In the first 5 days, you can use it at any time without any further precaution. And from 1 week, if you choose the coil as a method now. Otherwise, you can choose it at any time with an extra method of protection like condom, for 7 days or 9 days, depending on the type of contraception you're using. Do you have a question, Donna? Is it clear?
Yeah, it does make sense actually. But okay, so like I cannot use the combined pill now. I have to wait till my next period.
Yes, absolutely. That is very good. I can see that you're retaining everything I say, and that's very good.
Doctor, what if I have an unprotected sex again?
That is fine. Don't worry about it. Depending on what you choose now method, if you choose the coil with the coil is there, will prevent any in the future, but you need to contact us because we need to do some tests, blood tests and swabs from down below. We may need to give you, depending on if it is somebody you know or not, depending on that, we need to give you some prophylaxis for some diseases, and we encourage you to take safe sex and use condoms. Is that right, Donna?
Yeah.
Do you have any question?
No, thank you, doctor.
You're welcome. You're welcome.
About it, and we'll get back to you.
Yeah.
Thank you, Wafa. Thank you, Mariam. Perfect, Wafa. Mariam, as a lay examiner, what's your evaluation of Wafa?
Very well done, I must say. Very reassuring attitude, very open questions, very welcoming. She was reading my expressions that I want to ask questions, and the welcoming behavior for the questions, like, yes, it's a very good question. And then even if I want her to repeat something for my reassurance, she was doing it too. She was maintaining confidentiality, which was good. She was hinting towards what are the safe practices. Her language was not at all a medical jargon, which was very easier for a layperson to understand. And the way she signposted before the sexual history and pick up the point of FGM was great. I will definitely like to see her as a doctor in future too, as a patient. Yeah, perfect.
So thank you, Mariam. Okay, next task will be the emergency contraception with the LITs. As usual, exceptional, very impressive, very well done. Let's go through the task, then we will take the clinical examiner evaluation. Now you have the lay examiner evaluation from her point of view, and definitely you passed all the points of the lay examiner, you did it. So if there is a lay examiner in this task, you already had the points of the lay examiner, you have the marks of the lay examiner. Very good introduction. All the templates or the points of our templates are mentioned here. So the introduction, you made a good rapport. I like your way of reassuring her, of smiling. This is a lady who missed her bill. It's not a big issue. Don't your tone up and down. This will be a welcoming attitude. So by the end, Mariam is telling you, I will be happy to see you as a doctor in the future. Okay, so this will be a comment of the lay examiner. Exploring the concern and expectations, you mentioned the agenda in details and the history. Already had all the important points of the history, and signposting before the sexual history, signposting in any task from the sexual and reproductive health. So when was the unprotected intercourse, you should have asked about the last menstrual period, and you asked, and the confidentiality, you already maintain the confidentiality from the start. She's 18 years old, okay, and she has a boyfriend, and she has no other partners in the last 6 months. So now you are asking about the sexual intercourse, if it is consensual or no, if she agrees for it or no, if she's with someone she knows or no. These are the important points that has to be asked in this scenario. If in another task it was with someone she doesn't know, and it was without her consent, the task will be twisted and will go into the task of female sexual abuse. So asking these questions are very important, because you may feel that the task as a task of emergency contraception at the start, but you will be surprised at the end that the task is about sexual abuse and there is hidden agenda. So these questions are very important. Signposting, confidentiality, and ask about the partner, especially when you find a teenager coming asking for emergency contraception. You have to ask about the STIs, very important. The gynae history, the last menstrual period, again, you have to ask about the last menstrual period, if it is regular or no. This will make a difference, the timing of ovulation, and if she is on any other method of contraception. This question is very important, and you already asked it, and we mentioned at the start, some tasks she will tell you, yes, I'm taking the combined pills and I forgot only yesterday, and she's in the second week. This will again twist the task. So these questions are very important to be asked in here. Willing to continue contraception, now you are asking her if she's willing, and I liked when she told you that she's using the condom, you hit the point immediately, encouraging her to continue in the condom to protect her from sexually shared infection. Any other symptoms and obstetric history, medical history, because you have to exclude bronchial asthma, and you have to exclude if she's any other medications like antacids. She's using antacids, if she's having bronchial asthma at this point, so the L1 will not be an option anymore. The surgery and the female genital mutilation. Actually, this is not the classical task. The female genital mutilation is in another task. I asked Mariam to answer you nothing important. So when you find that the role player giving you answer which will not satisfy you are not feeling satisfied with the answer, you have to dig behind. There may be another hidden agenda. And there was one task before, I just added this point to this task just to tell you all to take care. If the role player answered in a way you are not satisfied with this answer, you have to dig behind the answer. The body mass index again is very important, and you asked about it, and if she is supported or no. So perfect and brilliant information gathering. Now to the options. Will you mention all the options, or you mention the options that are suitable in her case? You will mention all the options, but you will just tell her that we have the pills and we have the ICD. And exactly as you mentioned, we have two kinds of pills, Levonil, which is no more suitable in your case because it's now more than 3 days after the unprotected intercourse. There is another types of pills, which is the L1, which can be used up to 5 days. And then when she asked you about the copper coil, when she had horrible stories, you answered her concern at the point. You reassured her. You started the negotiation. You offered her all the points that relieve her concern and relieve her worries. So, mechanism of action, success rate, that it can be used as a long-term method of contraception, as the timing that it can be used after ovulation, and in another case, for after ovulation, the pills are not suitable, but here the pills are still suitable, but L1 not the Levonil. Now she will respond. The role player will be given instructions. If you reassure her, she will start coming down to ask you, what about the coil? Now she's feeling confident that she can go for it if you will counsel her about the benefits. So the nurse, the painkillers, the antibiotic cover, this is the only point that you didn't mention, right? Now you are, this is the only point that you didn't mention. The risk of perforation, didn't mention, risk of expulsion also, and can be used as a regular method or long-term method of contraception. You already mentioned this point. Other options, you may refer her to the contraception clinic later and you give her information leaflet already mentioned from the start in the agenda. That's why agenda is life-saving and marking saving. How I will know if it has worked and everything is okay? You already mentioned this answer without being prompted. So if your periods will be late, what you need to do, if it is more than 1 week, you need to do pregnancy test and you have to come back for urgent ultrasound to exclude the possibility of pregnancy outside the womb. You mentioned the nickel allergy in a very nice way in between. So I like your way, Wafa. I like that you are not waiting for the role player to ask you. The red flag signs and when to come back are very important in this case. So what if I had emergency bills before 2 years and I was very sick and nauseated? You answered this point also during your discussion that vomiting, you will offer antiemetics, and if she vomited 2 to 3 hours, you will repeat the dose. This is very important as a safety point. Sorry, because of the animation, I didn't care of this one. What if I want to start the combined pills? Definitely, you answered as we mentioned at the start. What would happen if it doesn't work? Again, this is a repeated answer. Again, if the period is delayed or more than a week or 3 weeks from the unprotected intercourse, you will come back for a pregnancy test. And if the pregnancy is positive, it will depend on your wishes. If you want to terminate or if you want to continue, will depend on your wishes after counseling later. If she's overweight in another scenario, again, the ICD or Levonil. What if I had unprotected sex again and she is on ICD? You reassure her that this is a long-term method of contraception, so no need to worry about it. Again, if the unprotected intercourse in another scenario with someone she doesn't know, at this point you will recommend investigation for other sexually shared infection or other sexually transmitted infection, and you may offer her post-exposure prophylaxis, but this will be if she's coming with someone she doesn't know or if she's coming in a case of sexual assault. Wafa, you are now the examiner. Evaluate yourself.
I believe I passed this domain.
Definitely passed.
I've tried to concise my history. I hit on the last period and the time of unprotected sex, because that will also give me a hint on the reliability of the patient, her BMI, contraindication and indication, and drugs.
Okay. So these points are very important, especially the last menstrual period and the time and the number of unprotected sex. If you didn't mention this point, you will fail in the information gathering, whatever you will do. By the way, Wafa, try to reduce the time that you spent in the information gathering. You spent 5 minutes and 30 seconds, which is 1 minute more than our upper level. Okay, so you managed to finish, you managed to mention each thing in the task, but please take care. Okay, so the information gathering you passed, the communication, You don't have the chance to comment about the communication because already Mariam, she mentioned everything. You are a very good communicator, very reassuring, and there is no blaming, especially in this task. Okay, you give a clear explanation in a lay term. Signposting before sexual history is very important. Reassurance about the confidentiality. You mentioned these 2 points. Each one of these points are borderline. If you didn't signpost, if you didn't reassure about the confidentiality, you will take a borderline in the communication, whatever you will do. Then consultant appointment and patient information leaflet, already mentioned early in during his agenda, so brilliantly passed in the communication. Okay. Now, the safety. Wafa, safety.
I have missed the antibiotic, definitely, which is a big issue because she is high risk. As you mentioned in your previous video, in February, she's a high risk patient because of her age, so that's very important. I missed that. I touched point on the contraception of GM, so depending on the intelligence of the examiner. Okay,
so the point of antibiotic is important because she's one of the vulnerable groups, okay? But you are lucky here because it is not a borderline or it is not a failure point. So because you mentioned all the points, we will give you pass here in the patient safety, okay? So last is applied clinical knowledge.
I believe I passed in this one, although now from your explanation, I think I made her a bit confused because she asked me if I have another unprotected. So from your explanation, that it's now clear for me. If she asked that, that will depend, the manager will depend on her answer. If it is with someone she knows or she doesn't know. If it is someone she doesn't know,
no, this is additional point to this is additional point. Okay. No, don't open another agenda. This is an added point to the task. No, if she has an additional intercourse, now she is on ICD, so no worries. If you are going to put the ICD, this will be considered as a long-term method of contraception, so no worries here. Reassure her. She needs only reassurance. Okay? So again, you passed in this task. The point of female genital mutilation, it is an added point in this task, so I can consider the additional time you spent in this task. I will cut it in the point of female genital mutilation and that you went behind this point. So I can say also that you had a good time management, but please reduce the time for the information gathering.
Yes, absolutely taken. Thank you very much.
Brilliant.
For the female, thank you very much. For the female genital mutilation, I didn't understand, so I thought maybe you put it because if she has type 3 and she wants a coil, she may need defibrillation.
Yes,
so I thought that
exactly.
That's why.
This will be in the other task. In the other task, she will tell you that my partner, it is always telling me I'm tight from down. I have problems, I have infections, and I feel small from down. I have pain during the intercourse. So all these are indications. So you will offer her defibrillation at the time of insertion. So this will be the additional point in the management in the other task if she came with female genital mutilation. But as I told you, the classic scenario which appears in the exams before, there was no female genital mutilation. The female genital mutilation was all the recall. Okay?
Thank you very much. Thank you for your feedback. Very valuable. Thank you.
Very, very well done, Wafa. Thank you. Thank you as usual, as our expectation.
Thank you very much for Mariam as well. Thank you.
Okay. So this will be for the emergency contraception today. Thank you so much. I hope it was useful. If you find it useful, share it with your friends and remember me and my family in your prayer.